I'm streaming. What? Okay, hey, this is Howie, and it's about midnight, and I'm just studying. I'm getting ready to type my first large term paper essay, so I can get a. So just so I won't be behind in school, and that I can make sure that I'm ahead of the game, because I know that because I'm working full time and I'm going to school full time, I'm gonna fall behind. So I decided to forego Taco Tuesdays with some of my classmates, which sucks. And I'm alone here at home, but I'm comfortable and I don't have to work tonight. So I'm gonna do my best to get this first draft ready to go. All right. So stay with me. Hang around if you want. Ask me questions while I'm live. This is an experimental beta live for the first time. So if you happen to catch me, you can study with me. Yay, how boring is how boring am I? I gotta go pee. Okay, I'm back. My topic in nursing is going to be EMDR, and it's one of the treatments that they use for PTSD. And I work with a lot of veterans, and I know a lot about PTSD because I'm a veteran myself. So I'm going to read this and try to see if this PDF is going to give me a good rough draft outline of my term paper. Okay. Hey. Oh, and this is my kitty cat, Oria. You might see her. Hi. Say hello to the viewers. Hey. All right. So weird. Technology is crazy. Well, since nobody's studying with me anyway, I'll read out loud. Title: EMDR, Implications of the Use of Reprocessing Therapy in Nursing Practice. Trauma and the associated disturbing memories that can result are a common reason why individuals seek mental health care. While many treatment modalities can provide relief to patients experiencing trauma memories, perhaps none is so acclaimed, so scorned, or so steeped in controversy as eye movement, desensitization, and reprocessing, also known as EMDR. Reasons why this therapeutic intervention is gaining popularity include the apparent simplicity of the procedure and reports of dramatic, rapid improvement after only brief treatment with EMDR. Yet while volumes of case and anecdotal reports attest to the value of EMDR in reducing complex patient symptoms, questions linger regarding the scientific basis and empirical evidence supporting rational use of the modality. In surprisingly polarizing fashion, EMDR is touted as either science or wizardry with little middle ground. As EMDR continues to attract attention, nurses in clinical practice need a basis for deciding if this treatment is a neurobiological-based repatterning of neuronal information storage or if it is a mesmeric, placebo-based ineffective treatment. This article attempts to wade through the rhetoric and reports and examine the available evidence base for the use of EMDR treatment in psychiatric nursing practice. It examines the known and hypothesized scientific basis for the treatment, the levels of empirical evidence regarding efficacy, and the indications and counterindications for its use. This knowledge is essential for psychiatric nurses who want a framework for decision-making to allow accurate discussion of this treatment with patients and or for deciding to use or refer patients for EMDR treatment. Let me see what I sound like. To allow accurate discussion of this treatment with patients and or for deciding to use or refer patients for EMDR treatment. Let me see what I sound like. Oh, I'm offline. Why? EMDR, what it is and where it came from. A patient is troubled by intrusive and disturbing memories of past traumatic events and is feeling a significant level of distress. He seeks help from a therapist who quickly moves a finger back. Oh shoot, that's loud. That's me. Where was I? A patient is troubled by intrusive and disturbing memories of past traumatic events and is feeling a significant level of distress. He seeks help from a therapist who quickly moves a finger back and forth in front of the patient's face, all the while asking him to hold traumatic images and memories in mind, and then asking the patient to shift associated memories to positive thoughts. After this activity, the patient self-rates his level of distress, and treatment is continued until significant improvement is noted. That is the core of EMDR treatment. While it appears simplistic, some components of... Wait a minute, so... He just wiggles a finger back and forth? Is that what this whole treatment is? Who quickly moves a finger back and forth in front of the patient's face, all the while asking him to hold traumatic images and memories in mind, and then asking the patient to shift associated memories to positive thoughts. After this activity, the patient self-rates his level of distress, and treatment is continued until significant improvement is noted. That is the core of EMDR treatment. While it appears simplistic, some proponents have reported serious disabling symptoms being extinguished in patients with as little as one 90-minute EMDR session. Such reports of almost miraculous recovery have been widely circulated and have fueled the almost legend-like belief among supporters of the value of EMDR. So basically, I guess a therapist is just going woo and trying to see if you have any traumatic events that you're remembering, and then you rate it based on how your eye movement. Interesting. Very interesting, and I think this is going to be an interesting paper. I just hope I get enough sources. Anyway, so there's about 10 pages, so probably half of that is bibliography, but let's read on. EMDR, a form of psychotherapy, was originated in 1989 by psychologist Francine Shapiro after a chance observation while walking in the woods. She noticed that moving her eyes rapidly from side to side appeared to lessen the intensity of her own disturbing thoughts and related anxiety. Shapiro tested her notion on post-traumatic stress disorder patients and reported significant improvement in their subjective distress levels after the treatment she called EMDR. So it was back in the 80s by Francine Shapiro, and moving her eyes rapidly from side to side appeared to lessen the intensity of her own disturbing thoughts. It's so weird. It's a very good observation. Despite original reports that EMDR is a complex technique requiring extensive training, it is now being taught in brief workshops and used by a wide array of practitioners in diverse settings. While perhaps complex in its actions, EMDR can be described in deceptively simple terms. It is perhaps best described as the intentional induction of rapid, rhythmic, saccadic Eye movement in order to assist an individual to desensitize linkages between experienced events and emotionally loaded memories. EMDR shares goals common to other desensitization therapies with the chief aim of making individuals so accustomed to the traumatic memories that these lose their distress-inducing capacity. As the therapist moves her finger in front of the patient and as the patient tracks the movement with his eyes, the patient is asked to concentrate on traumatic memories. While traditionally using the therapist's finger, EMDR practitioners have increasingly experimented with other processes, including hand or toe tapping, alternating sounds, and mechanized visual fixation props as alternative to finger movement. What if we use you as a prop? Look at the cat. Look at the cat as a prop. Alright, you're not into it. Okay. Supporters of EMDR contend it should be undertaken only by licensed mental health providers who have been adequately trained in its use. To date, more than 20,000 mental health professionals have been formally trained. Standards set by the EMDR International Association require a minimum of 18 hours of lecture content, accompanied by 13 supervised clinical hours, with 31 hours of training seen as a minimal training before a provider should attempt EMDR with patients. While some trainers have provided less rigorous workshop trainings, the EMDR International Association, also known as EMDRIA 2000, criteria are widely accepted. Additional stringency for approved trainers, consultants, and supervisors has been identified by the EMDR International Association, and I don't need a license to do that, so that's cool. EMDR shares obvious theoretical and procedural commonalities with cognitive behavioral therapy, hypnosis, and other desensitization psychotherapies. During the EMDR procedure, patients are asked to confront negative perceptions and to alter cognitive beliefs. In fact, many believe that shifts in cognitive perceptions rather than any effects of eye movement are the basis for positive outcomes reported with EMDR. In addition to CBT, EMDR shares commonalities with hypnosis, guided imagery, exposure desensitization therapy, and neurolinguistic programming as treatment modalities because of its high reliance on visual fixations, visual image replacement, and eye cognitive linkages as therapeutic strategies. Indications for and use of EMDR. Sorry, I gotta lick my lips a lot. There's food in my braces, so excuse me. Sorry. Indications for and use of EMDR. EMDR has most consistently been used as a treatment modality for PTSD, a common disorder usually treated in outpatient settings. PTSD is a disabling condition that has been associated with significant negative health outcomes, including diminished self-reported sense of well-being, obesity, substance abuse, fibromyalgia, polycystic ovary disorder, cancer rates, and asthma. Because of the disabling nature of PTSD symptoms and the common comorbid syndromes associated with chronic PTSD, effective and rapid treatment of symptoms is essential. By far the largest volume of case reports and research about EMDR examines it as a treatment for PTSD, with many sources seeing EMDR as a practical, cost-effective, non-invasive, and therefore appropriate treatment for PTSD. While most commonly used in treating PTSD, EMDR is one of many useful treatments for this disorder. Table 2 compares EMDR to other commonly available treatments for PTSD. EMDR is increasingly being used as a psychotherapeutic treatment for a growing multitude of disorders like speaking, eating disorders, morbid jealousy, wow, that's a lot of jealousy, chronic pain, depression, and anxiety. Table 3 references scholarly works that report these extensions to suggested indications for EMDR treatment beyond PTSD. The increasing utility of this treatment has once again fueled the debate about the procedures and whether it is scientifically sound or defensible. Some have linked the growth of EMDR to aggressive marketing rather than scientific evidence of efficacy. Whether or not one believes EMDR has been aggressively marketed, EMDR has spawned a growth market of internet sites, training seminars, manuals available for purchase, and the marketing of expensive treatment equipment, including eye scanners and other visual mechanized devices. Because of the wide use of EMDR and the polarizing nature of claims of clinical efficacy, it is not easy to identify when EMDR would be most appropriate or when it would be contraindicated. It is clear that very limited data exists identifying any negative effects from EMDR therapy, leading to a general acceptance that it is an overall safe treatment. Only one study could be found that identified case-specific negative consequences of EMDR use. EMDR should be used with caution in special populations because of the very limited available data regarding its use with children, pregnant women, the elderly, comorbid, or other vulnerable populations. It is also unclear if it is a safe treatment in neurologically compromised patients, such as those at serious risk for seizure. With a growing list of suggested conditions for which EMDR can be used, and a growth market of training and equipment, the obvious question becomes, how does EMDR work, and is EMDR a clinically effective treatment? That is a thesis right there, and I'm going to highlight that. Very important main idea, which I'm hoping to address. Okay, moving on. Science integration or placebo, how EMDR works. Much of the intuitive appeal of EMDR for clinicians relates to the apparent simplicity of the treatment procedures and the speed at which clinical improvement is reported. It has an intuitive mystical appeal that is in many ways similar to factors that have assisted hypnosis to flourish. Even the most enthusiastic supporters of EMDR cannot say in cogent bioscientific terms how it works. How EMDR actually produces the purported outcomes remains an issue of intense speculation and theorization. Shapiro, the therapy's founder, has elaborated on two theoretical models to explain the action of EMDR, both evoking elements of integration as a scientific basis of action. These models of mind and brain. Shapiro argues that EMDR, while affecting psychological aspects of functioning, has a clear neurophysiologic impact that is responsible for the therapeutic benefits. Good claim. Let's see if we can prove it. She contends that EMDR somehow synchronizes electrical activity, thereby altering conditioned fear responses to memories of the original trauma. While accepted by many, the integrative mind-brain component theory proposed by Shapiro has led to skeptics believing that as a treatment, EMDR theoretical models of action are vague at best and foolish at worst. Others have speculated that any benefit is either placebo-based or related to the therapeutic, big words here, interpersonal relationship between patient and therapist, rather than eye movement or informational processing. This is a good question. I wonder if I can use this article as one of my article presentations and still use it as a reference for my rough draft of my term paper. I'm going to email my professor that. Give me 1 minute, sorry. Professor, may I ask you a question? What was her name? Oh, yeah. Database access and using referenced article. Hi, Professor. I was wondering how we can access the databases through our university library. I only found 1 or 2 databases specifically for nursing and allied medical departments. Through those, I have found few articles for my chosen topic EMDR for PTSD. I know you wanted references with nursing, you wanted references only from the nursing specialty, but can I add some papers from other healthcare providers, such as psychiatrists as well? Questions for you. And 2, what was my question again? My second question was, oh yeah. Also, may I use a referenced paper for my term? Oh, may I use a reference article on my term paper for presenting? For the article presentation assignment? Best, Howie. Hi, Professor Holt. Questions for you. 1, I was wondering how we can access the database through APU, I was wondering how we can access the databases through our university library. I only found 1 or 2 databases specifically for nursing and allied medical departments. Through those, I have found a few articles for my chosen topics. I know you wanted references only from the nursing specialty, but can I add some papers from other healthcare providers, such as psychiatrists as well? Also, may I use a reference article on my term paper for presenting for the article presentation assignment? Okay, alright, that sounds good. We'll send her that. Hopefully that doesn't wake her up. Oh, shit. Hey, don't delete my description. Who's watching? Oh, weird. That's cool. Somebody's watching. Hello? How you doing? Thanks for watching. Wait, I want to copy this thing right here. Yeah. I want to, just so everybody knows that I'm talking about EMDR therapy, I want to copy this description and update it. Come on now. Come on. There you go. The subject is EMDR, which is I don't even remember the meaning of the abbreviation for EMDR. Eye movement desensitization and reprocessing therapy. Eye movement desensitization. Do I have to capitalize that? I don't know. Desensitization and reprocessing. Okay. Alright. Saving that. Okay, let's get back to reading the thing. Where was I? Here we are. EMDR is increasingly being used as a therapeutic treatment for a growing multitude of disorders in addition to PTSD, including such diverse problems as addictions, pain management, panic disorder, dental fears, phobias, body dysmorphic order, fear of public speaking, all that stuff. Eating disorders, morbid jealousy, chronic pain, depression, and anxiety. Okay. Okay, here's the next topic. Or same topic, different heading. Science, integration, or placebo. How EMDR works. That's pretty interesting. Much of the intuitive appeal of EMDR for clinicians relates to the apparent simplicity of the treatment procedures and the speed at which clinical improvement is reported. It has an intuitive, mystical appeal that is in many ways similar to factors that have assisted hypnosis to flourish. Even the most enthusiastic supporters of EMDR cannot say in cogent bioscientific terms how it works. How EMDR actually produces a purported outcomes remains an issue of intense speculation and theorization. Shapiro, the therapy's founder, has elaborated on 2 theoretical models to explain the action of EMDR. Oh, wait. How many people are watching now? Oops. Sorry. Okay, Shapiro, the therapy's founder, has elaborated on 2 theoretical models to explain the action of EMDR, both evoking elements of integration as a scientific basis of action. These models, first called the Accelerated Information Processing Model, and now revised to the Adaptive Information Processing Model, conceptualize memory and its effective storage as an integration of mind and brain. Shapiro argues that EMDR, while affecting psychological aspects of functioning, has a clear neurophysiologic impact that is responsible for the therapeutic benefits seen in PTSD. She contends that EMDR somehow synchronizes electrical activity, thereby altering conditioned fear responses to memories of the original trauma. While accepted by many, the integrative mind-brain component theory proposed by Shapiro has led to skeptics believing that as a treatment, EMDR's theoretical models of action are vague at best and foolish at worst. Others have speculated that any benefit is either placebo-based or related to the therapeutic interpersonal relationship between patient and therapist, rather than eye movement or information reprocessing. While models of how EMDR works remain hypothetical and have not been fully tested, they have been criticized for lacking correlation to known brain structures. Additionally, as EMDR is used for more and more diverse health problems, many of which have well-identified neurophysiologic etiologies having little to do with information reprocessing, it is hard to find a physiologically based theoretical model of EMDR's action that would explain equal efficacy for such diverse problems. Additionally, as EMDR procedures are expanded to replace saccadic eye movement with finger tapping and/or auditory focus on sound, some of the original theories pertaining specifically to eye movement, quote-unquote, freeing up memory displacement, become even harder to understand. It has been suggested By some, that the real benefit of EMDR reported in some studies may be linked more to its ability to distract and or relax the patient rather than any ability to free trapped memories. One of the first studies to examine how EMDR affected neurophysiology employed neuroimaging techniques, examining subjects diagnosed with PTSD using single photon emission computed tomography SPECT studies prior to and following 3 EMDR sessions. The authors concluded that patients experienced subjective improvement in stress levels, while SPECT scanning suggested two areas of the brain. The anterior cingulate gyrus and the frontal lobe were hyperactive post-EMDR. It is a function of the cingulate gyrus to shift attention from one thing to another, whereas the frontal lobe is involved in associative and affective aspects of cognition. This study is limited by a very small sample size and its lack of a control group, but it provides a starting point for models hypothesizing the action of EMDR. The cingulate gyrus has been identified in other studies as an area of impact for desensitization therapies, including hypnosis, and therefore a logical area of hypothesized EMDR action. More recent work has looked at stress chemicals and neuroendocrine responses as a window into measuring the impact of EMDR and identifying its actions. Studies have shown that EMDR increases basal cortisol levels and produces more attenuated cortisol hypersuppression in response to dexamethasone suppression tests in PTSD sufferers. I think I'm going to do a biochemistry focus on this one. Since that's my major, I could probably talk about that a little bit. Biochemistry discussion. Maybe not go into it too much, but just a little bit. This suggests that neuroendocrine measures may be of some assistance in future studies in the assessment of EMDR treatment procedures' impact on the clinical outcomes of the patient over time and may well lead to a clearer understanding of the neurobiological basis of reported efficacy. Perhaps the most complete, logical, and parsimonious theory on how EMDR works is contained in the work of Stickgold, 2002. This theoretical model attempts to explain the therapeutic benefits of the saccadic eye movements of EMDR. Proposing that the induced eye movements in EMDR mimic rapid eye movements, REM, of sleep, the model attempts to identify the neurological pathways of the cortical integration of traumatic memories that was alluded to in Shapiro's early works. This emerging model provides a reasonable explanation for EMDR that is consistent with modern neurobiological understanding and is a first step toward a more universally acceptable neurologically logical theory. Neurologically logical theory. That's kind of a long sentence. Don't worry. Stickgold's model suggests that REM states are facilitative of memory integration, and EMDR may cause cholinergic activation on the brainstem that jumpstarts the REM induction mechanisms of memory induction in associative cortical areas. One limitation of this theory is the assumed causality between eye movement and clinical improvement in its examination only of EMDR done using eye movements. It is much less helpful in explaining reports of EMDR's efficacy in other health states or when done with hand motions or sounds rather than with eye movements. But it begins to provide a clear and testable neurobiological theory of EMDR action. Okay. How does my viewers left. It must be really boring. Oh well. Keep on going. How does EMDR work? No one can say with any degree of certainty. Okay. Without this knowledge, it is difficult to decrease the controversy over this treatment or to assure clinicians and patients that it is an effective treatment. That's kind of a main idea. As cogent models of EMDR's actions emerge, testing will advance our understanding of this therapy. While work continues on developing such a cogent, parsimonious, and logical theory, there remains a lingering question of its efficacy as a treatment. Does EMDR work? Clinical efficacy and the nature of evidence. Morano in 1994 touted EMDR as a wave of the future, This promise has failed to materialize largely because of lingering questions regarding the efficacy of EMDR treatment in mediating targeted symptoms. This is not for want of trying, and there is a plethora of studies examining the efficacy of EMDR as a treatment modality. Yet, despite the extensive literature, there remains no consensus about the efficacy of EMDR. I wonder how this is. I wonder how everybody else researched the efficacy of other treatments like prolonged exposure. What successes did other treatments provide? Examples such as what successes? Examples such as oh yeah, prolonged exposure therapy. PE, prolonged exposure. Studies can be found that conclude EMDR works, many written by ardent supporters. Just as many can be found that conclude little or no benefit from EMDR. That's not a surprise. Research is confusing and contradictory. Greenwald, for example, found no effect from EMDR treatment for children with PTSD. Much of the debate over efficacy is centered on whether a true measurable effect exists consistently because of EMDR treatment. Effect is most often and most compellingly established by controlled clinical trials, where EMDR would be compared to other standard treatments, to no treatments, or to a placebo treatment. These studies are largely absent, and the few studies that purport to be controlled trials and found EMDR effects have been repeatedly cited as being significantly methodologically flawed. Ouch. Identified flaws in studies that have found an EMDR effect include small sample size, lack of randomization, lack of diagnostic similarity among subjects, lack of standardized instruments to measure clinical improvement, and serious lack of control over other treatments that subjects were concurrently receiving. All these limitations make it very difficult to say with any certainty that a clinical effect occurs with EMDR or that EMDR is efficacious in the treatment of PTSD or other related disorders. One of the most thorough recent reviews of existing studies on the efficacy of EMDR was conducted in 2001 using meta-analysis. This meta-analysis concluded after a review of extant studies that EMDR appeared to be no more effective than other exposure therapies, and that the eye movement, the procedure for which it is named and which is a hallmark of the therapy, is unnecessary, and that patients derive similar benefit no matter what physical action the therapist performed. Such findings, juxtaposed to continued anecdotal and case reports of almost miraculous improvement, continue to fuel the controversy surrounding EMDR. So it's not looking good so far. Take a stretch. Oh my god, what time? Okay. Some of the controversy over efficacy of EMDR can be framed within the debate over what constitutes evidence of efficacy, an issue of growing concern in this era of evidence-based care. While the debate regarding evidence-based care is beyond the scope of this article, supporters of EMDR continue to contend strongly that it works, dismissing the failure to establish effect through rigorous controlled clinical trials as an issue for scientists, not clinicians. This schism over what is acceptable evidence is further exemplified by the reality that EMDR is most often embraced and used by practitioners with formal research training and who are less programmed to believe randomized clinical trial data are necessary to establish efficacy. These clinicians have more comfort accepting evidence at the level of personal experiences, responses of known patients, and other case and anecdotal reports as sufficient to support their use of the therapy. Well, why don't they just randomize the patient's results by taking a survey or giving them a survey? Is EMDR clinically effective? The answer to this question is as unclear as the answer to how EMDR works. Nobody knows nothing, basically. Some say it works and some say it doesn't. Critical evaluation of empirical data regarding the efficacy of EMDR is difficult and is influenced by one's own stance on the debate over what is evidence of efficacy. The literature on EMDR suffers from lack of a cogent theoretical, biologically based model explaining the effects of EMDR. The lack of a theoretical model explaining how EMDR works makes it difficult to reproduce PTSD or other symptom cluster for experimental controlled research studies. In addition to lack of theory model and the identified methodological flaws, many believe that there has been overt biased dissemination of study findings by a small number of authors, making final conclusions concerning the efficacy of EMDR very difficult. EMDR and nursing practice. I gotta take a break. Give me like a minute. I just gotta pee, stretch my legs. Ugh. Just a second, I gotta wash my hands. Oh my god. Okay. I'm still alive. Still alive. Wow, it's been 42 minutes. EMDR and nursing practice. Whoa! For a therapy now more than 20 years... Oh, I didn't know it was that old. Now more than 20 years old, EMDR remains unusually controversial. The evidence base for EMDR is confusing. Clinicians remaining divided into camps of believers and non-believers. It is difficult for nurses to determine whether they should incorporate EMDR into their clinical practice. It should be remembered that even the most ardent supporters of EMDR assert it is most effective on the anxiety and distress subjectively experienced by patients, but it is not a panacea for all PTSD-related symptoms. Okay, I'll highlight that. I mean, that's kind of common sense, but still. One of the few nursing publications that can be found pertaining to EMDR describes the treatment and supports the use of EMDR. This work typifies the complexity surrounding EMDR and the confusion that exists regarding efficacy of this controversial treatment. Barron et al. Discusses in their summary that as a result of EMDR treatment, EMDR processes, images, memories, associations, thoughts, and emotions. Their conclusion is fully supportive of nurses using or referring patients for EMDR, because after use of EMDR, a neurological event has occurred. They recommend EMDR for a wide array of patients, including those suffering from PTSD, anxiety, phobia, depression, or any neurotic symptom. They base these recommendations on a stated belief that traumatic events upset the balance of the brain's information processing center, and go on to discuss how this imbalance prevents the information from proceeding to an adaptive resolution, and perceptions of the trauma incident are locked into the nervous system. Such non-specific, unscientific, non-evidence-based mumbo-jumbo becomes an indefensible rationale for the inclusion of a treatment into a nurse's clinical practice. Psychiatric nursing is a science-based practice, and nurses must carefully weigh the scientific evidence and rationales for practice treatments. That is not at all to say we should avoid all as yet unexplained treatment. Healthcare often uses unproven treatments or treatments supported solely by untested theory or unclear efficacy data. What is important is to acknowledge the degree of available evidence and our limitations in current understanding. This allows one to be open to emerging explanation and evidence of efficacy, including the possibility that unproven treatments may be highly effective or have placebo effect only, or at worst, prove to be unhelpful and dangerous. Patients have a right to a balanced discussion of available information, an understanding of the rigor of evidence, and nurses must be able to defend clinical decisions based on science. Conclusion. It is a conclusion of this author that clinicians should approach EMDR with a degree of caution until more rigorous, conclusive models of action are developed and until stringent empirical establishment of efficacy occurs. EMDR is by most standards seen as an overall safe treatment, most appropriately used for PTSD-related treatment. The decision to use EMDR in clinical practice needs to be personal, based on thoughtful clarification by individuals of what, for them, constitutes the necessary and sufficient evidence that must be present in order to adopt the use of a treatment strategy. The interface of clinically meaningful findings and research-driven evidence will most likely remain a contentious professional issue for the foreseeable future. The decision to use or reject EMDR as a clinically meaningful treatment modality should be based within the science of our profession. While tempting to be swayed by urban legend level reports of miraculous cures, the evidence is less persuasive and cannot be ignored. EMDR is controversial. It has no proven basis of action. It has no empirically sound base supporting its consistent efficacy. These realities must be mediated by our understanding that this is how many of our best treatments started. Caution is warranted. Hope is appropriate. Wow, that's a really good paper. All right. Well, that was my first live stream. And again, that was EMDR, Implications of the Use of Reprocessing Therapy in Nursing Practice, written by Dr. Susan McCabe. All right, great. If anybody has any questions, feel free to email me or message me. I don't know how. Oh, through YouTube, or just subscribe to my channel. Bye, guys. Good night.